Salam. My name is Rasha Kuran, and I have no. And here are my objectives. We're going to overview the current state of affairs, available vaccines, and their platforms As of September 30, 2022, when I made this slide, there have been more than 6 million documented deaths. Globally. And at this time, we are still seeing 5 like things are much better, and they are better, but this is still going to be an ongoing problem. And we will also go over what we expect for this from now on at the end of this presentation. So if we focus on Jordan, and as of September, again, 30, 2022, so while the world now is in a much better place and better shape, we still have challenges when it comes to vaccination. These So this map depicts vaccine equity. You could see that countries depicted. So to go over vaccines and how they work, just quickly, vaccines concentrate on utilizing the spike molecule, which is a molecule present on the And to zoom in on it, you could see in the green part, that's the receptor binding domain. So mutations in that part would be the most detrimental, affecting. There have been around 47, and these are the top used. In Jordan, these are the 4 vaccines that are at least online, are officially adopted or approved. Vaccine. And according to the WHO, there are about 172 vaccines clinical development. So vaccine platforms that have been utilized so far include whole virus, whether replication competent, or what we call live attenuated, or whole inactive. So inactivated whole virus vaccines are one of the most popular platforms. They are produced by growing SARS-CoV-2 in cell culture and then chemically inactivating the virus. They are often combined with an adjuvant to stimulate the immune response. The Sinovac, Sinopharm, and Bharat Biotech vaccines belong to this platform. It has been previously used to make hepatitis A vaccine, inactivated polio vaccine, and its advantages include the fact that you can mount an immune response to multiple components of the virus, and therefore the immune response might be more maintained. Excuse me. Then live attenuated vaccines. Potential platform. Now, viral component, we have mRNA vaccines, and those consist of messenger RNA encoding target genes embedded in lipid nanoparticles. Once administered, these translate into target proteins like the spike protein, which elicits an immune response. Now, there have been no approved vaccines utilizing this platform prior to Uh, viral component can be also delivered through a vector, and those are a shell of another virus where you put the genome of the virus inside the other virus. The other virus could be replication competent or replication incompetent. The Johnson & Johnson vaccine belongs to the replication incompetent group, and that utilizes adenovirus 26 as a shell. The Chadox AstraZeneca vaccine utilizes a chimpanzee adenovirus vector. The Jamalaya Sputnik V vaccine is also a vector virus vaccine, which utilizes two different shells or two different vectors, in one for the first dose and one for the second dose. And then the surfaces. This is just a depiction of the Sputnik V vaccine, where it utilizes the second dose. Uh, Recombinant protein vaccines are another type of viral components. The main example here is Novavax, where it is essentially composed of purified viral proteins that have been expressed DNA vaccines. Um, uh, these are usually segments of plasmid DNA that contain mammalian expression promoters and target genes. Once in the recipient, these will produce the target protein. Popular. So at the beginning of the pandemic, when the initial studies were done, they showed really high efficacy and effectiveness. We're talking about after the and then with time, we noticed that 6 months after the receipt of the second dose, for example, for the BNT 162b2, which is the Pfizer BioNTech vaccine, the humoral response was substantially decreased, especially among men, among older individuals more than 65 years old, and immunocompromised. And so this, after real life data, this was also seen as decreased effectiveness in preventing infections. And that decreased to about 90% at 2 to 4 months after the primary series, and then 84% about 6 months after the primary series. And this is when people started thinking about boosters. However, observational studies that were done around that time showed that the efficacy against severe disease. So people looked at giving a booster using the same ancestral strain, and they found that this will the same for, and best of all, the protection after having had infection plus the. What about variants? So the virus that left China is called Wuhan HU1, And that's not the same that swept around the world. The one that did come to us was already slightly mutated, and that's the D614G. And so when they made the vaccines, they made them using the code of the original genome. However, those vaccines did protect against the D614G. Now, towards the end of 2020, we started having more variants, including the alpha, the delta. Those variants were slightly different when it comes to infectivity and virulence or severity of infection. And so but the vaccines maintained efficacy until the Omicron came out around the beginning or end of last year, beginning of this year, end of last year. And this variant does have more mutations in the receptor binding domain of the spike protein, and therefore it's more able to escape the antibody protection, and it also has more affinity to bind your own body receptors. So as you can see on the left, the bottom picture shows how many more mutations in the Omicron variant, and these are the red dots, and they're mainly this is a depiction of the ones affecting the receptor binding domain that makes it more likely to escape antibodies created or produced by the original strain. And this is a slide showing how animal studies show that neutralization of Omicron was undetectable in most vaccinees with the primary series after months and months of the original series. However, when boosted with the mRNA vaccine, the animals exhibited potent neutralizing activity even against Omicron variant, which was about 4 to 6-fold lower than that produced against the wild type. Now, this really suggests that boosting, even with the original strain, broadens the neutralizing antibody response against highly divergent variants. So even if we boost with the original strain, this does produce protection against more variants by broadening the immune response to it. Then people started making bivalent vaccines containing strains of the ancestral virus and variants. And so this was done in the studies. They used BA.1 Omicron variant combined with the ancestral strain. However, the one that's produced to be used in humans has BA.4 or 5. They have the same mutation sets included in the vaccine. So they tested the BA.1 and showed that the protection is significant in people who've had, especially who've had an infection prior to vaccination. So why do we get protected even long after the neutralizing antibody levels have waned? Is because of our cellular immunity, whether it's T cells or memory B cells that will hold this memory of having been infected, and so once someone is infected in the future, another neutralizing antibody boost happens in the future. So people who do not have the ability to mount cellular immunity are the elderly and the immunocompromised, and these are some of the immunocompromising conditions, including active treatment for solid tumors like chemotherapy, essentially solid organ transplant, CAR T cell therapy, primary immune deficiency and HIV, or active therapy with steroids. About 20 milligrams of prednisone a day for 2 weeks or more is considered highly immunosuppressive, or other chemotherapy. So those people will not be able to mount the cellular response and will depend on the humoral response that's triggered by boosters. And so boosters are more important for people who cannot really maintain a cellular immunity. So going over some of the main vaccine side effects, and I think most people are aware of them. We're just going to go over them quickly. Um, we have the Pfizer BioNTech mRNA vaccine. Um, all vaccines will have a similar local injection site effect and systemic symptoms such as fever and malaise. But for the mRNA vaccines, we have anaphylaxis and myocarditis, pericarditis as the main serious side effects. They are nonetheless rare, very rare, as a matter of fact. So they have been compared to being struck by lightning or being killed in an airplane accident. However, they are important to recognize and look for. Anaphylaxis in people who've had previous anaphylactic reactions to injections, especially, or people who've had an anaphylactic reaction to a previous similar vaccine. And the myocarditis, pericarditis issue happens mainly in young men. So you could see the numbers here. The highest incidence is in males 16 to 17 years old, where you can get up to 106 cases per million. Those are important to recognize. They're not always deadly or severe, but important. Similar for Moderna. Now, Novavax has possible risk of myocarditis and pericarditis. And then when it comes to the vector vaccines, such as the Johnson & Johnson and the Chadox, AstraZeneca vaccine, these have been seen to trigger, again, rarely, but importantly, a thrombotic phenomena, so thrombosis with thrombocytopenia. And the main people at risk here are women or females in the childbearing age. Also, Guillain-Barré has been reported. So this leads us to the current recommendation, and this is the CDC recommendations. These are the CDC recommendations for the United States, starting with people who are not immune compromised. So we have a distinction between the primary series and then the booster. They have completely removed the primary ancestral vaccine from boosting. So we cannot use it for boosting anymore, and only used for primary vaccination. So people who are 12 years old and older, the primary series is done with an interval, with 2 doses, with an interval of 3 to 4 weeks in between. So this is Moderna and Pfizer, as well as Novavax. And then after the second dose, it is recommended that everybody gets a bivalent booster about 2 months after. And again, it has to be with the bivalent booster. They removed the approval for boosting from the ancestral vaccines. People who receive the Johnson & Johnson vaccine, it's 1 dose, therefore 2 months after, it is recommended that everyone gets a bivalent booster. Now, for people who are immunocompromised, their primary series consists of 3 doses instead of 2. So they get, for mRNA, for example, 1 dose, and then 3 to 4 weeks later another, and then 4 weeks later another, a 3rd dose, then a bivalent booster 2 months after. For Novavax, it's 2 doses, 3 weeks apart, followed by a booster with the bivalent 2 months after. And for Johnson & Johnson vaccine, it is not approved for more than 1 dose, therefore you get the dose, and then 4 weeks later you get the 2nd dose for immunocompromised with an mRNA vaccine, and then 2 months later you get the bivalent booster. So some of the special considerations when it comes to vaccination. People who are receiving ongoing immunosuppression, what do? We still vaccinate them, and we try to do that about at least 2 weeks before initiation of immunosuppression, if that is possible. And for B-cell depleting therapy such as rituximab, it is recommended that you do vaccinate about 4 weeks before the next dose is due. Now, who who can be revaccinated. Those are the people who are going to wipe out your their immune system, such as hematopoietic transplantation or CAR T cell therapy. Those patients, you want to revaccinate them if they had it before, at least 3 months after the transplant. And people who get the rituximab or B cell depleting therapy, you want to revaccinate them about 6 months after receiving that. Now, someone can ask if we should check if we are immune or immune system is adequate prior to vaccination. This is not recommended because it's not really tested to show how high or which lab or what titer reflects immunity or not, and it's not recommended for whether it's cellular immunity or humoral immunity. So vaccinate according to the guideline and without any testing to guide that, because it's not accurate. Now, after infection or exposure, if someone was exposed, this is not a contraindication to the vaccine. We just go ahead and vaccinate. And these vaccines will not work for post-exposure prophylaxis, as we've recently seen for monkeypox, for example. And that is because the incubation period for this infection is shorter, way shorter than the amount of time needed for the humoral response to happen. So you'll be sick before your body has mounted the antibodies, and it would not work in that case. Now, what if someone had recently acquired the infection? You want to wait until they recovered and they've completed their isolation period and their symptoms improved. It's also reasonable to wait 3 months after, because they will be protected really well in that 3-month period. And then again, if it's not recommended to test people for active infection with like a PCR before vaccinating them. After giving monoclonal antibody therapy, whether it's the monoclonals or convalescent plasma, for treatment or post-exposure or pre-exposure prophylaxis, it is not recommended to delay vaccination. You just give it. However, after giving the vaccine, you want to wait about 2 weeks before giving the EvoShield, which is the long-acting monoclonal antibody therapy for protection in immunocompromised people. So after the vaccine, wait 2 weeks to give EvoShield, but after EvoShield or any other monoclonal, we don't wait to give the vaccine. You don't have to. And then what about pregnant or lactating women? There's been extensive work on this, and really the vaccines, at least that are approved in the United States, or those are the ones that we have the most work on, have shown, and actually most of the other ones have shown no effect on fertility. If anything, in lactating women, they might produce some protection to the babies, and there's no effect on outcome pregnancy. And weighing the risk and benefit of giving the vaccine during pregnancy, the main the main risk is if you get a low fever, that can potentially induce premature labor. So you can give Tylenol or fever-reducing medications that are appropriate in that case, but not the vaccine itself per se that would be causing any problems. And if we weigh the risk of getting COVID versus getting the vaccine, getting the vaccine is definitely much safer. And that's my talk, and I am now happy to take any questions you may have. Thank you again for listening.